Well, welcome to the Central Wisconsin Business Excellence Symposium. I am Chris Spranger. Just a little background about me. I have educational background in industrial engineering and business, and I started my career out in the aerospace industry, learning a lot about Lean and Six Sigma and what that can do in those types of industries, working in supply chains for companies like Parker Hannifin and General Electric, and getting to rub elbows with a lot of people who are called black belts and green belts, and having those certifications. The opportunity came in 2009 when the economy was not all that good, if you guys recall, to take a job at a healthcare system and launch a continuous improvement program there from the ground up. So designing the training and figuring out who's going to get trained, what the projects were, really growing that thing from the ground up. So it was a really good opportunity for me to expand my skills out of a widget building environment and go into somewhere that's really human dependent. So a lot of invisible processes or manually managed processes. And the one thing I learned when I was there was that these concepts I learned in manufacturing apply to virtually any business. In fact, I see it everywhere. I'm at Walmart, I see it at other stores, I see it out in the community. Just ways to do things better and more efficiently. And that's really kind of what's driven me to continue my career. I've got a consulting business now. I help people actually all over the country in various manners, implementing and helping to more effectively and efficiently run their businesses. This symposium was an idea that I had. I've gone over to the Fox Valley a few times. They have an event over there every 6 months. And people show up, similar to today, and they just hear people tell stories about how they're using these concepts in their organization. And I'm sitting over there, and I'm looking around the room, and I recognize a couple of people from Wausau, and I recognize a couple from Point, and I had a friend that was over from Wisconsin Rapids, and I'm thinking, why am I driving to the Fox Valley for this? Is there a way we can put together a community of people that would show up and get together in the Stevens Point, Wausau area and just talk about continuous improvement and learn from each other and grow our network? And that was kind of the idea. So I reached out thinking all I need is a couple speakers that know what they're talking about, which you guys will be the judge of that later. A couple speakers, I need a facility to have it, right? And I need an audience to show up. So I reached out to Kevin at UWSP. I don't know where Kevin is. Disappeared. Kevin back there. I kind of talked the idea with him and Jenny, who maybe, she snuck out. Okay, talked to them and I said, this is kind of the idea. And they said, we like to keep in touch with the business community with things that we're doing here. Yeah, we'll sponsor it and we'll let you, we'll have the facility and we'll see where this thing goes. So then I reached out to a few colleagues. Actually first, so thank you to UWSP for hosting and allowing us to be here, putting on the coffee, which is very, very important to me. Also, the Small Business Development Center helped spread the word and get the message out that this event was going on, having it be a relatively new event. We had to try to reach as many people as we could. I'd also like to thank our speakers, Joe, Craig, and Monica for stepping up and being willing to share a story today. And then also all of you for taking the time out of your day to really come. And it's not just taking time out of your day, but you must be here, right? You must be passionate about improving something, whether it's your own job, your business, making things more efficient. So I'm glad this whole thing could really come together. The agenda for today, so registration and refreshments, which many of you saw are over there. If at any point you need restrooms, they're located on this end and that end, down over there, outside in the hallway. Introduction, which I'm nailing right now. Am I right? Thank you, Craig. Try to keep it a little informal, right? Okay, so presentation 1, Craig is going to be talking about data-driven decision-making and how they're using data at Unitypoint Health. The second presentation, Monica is going to share a story about how they've improved their setup process in their press room at the Worth Company here in Stevens Point. And then finally, at the end, we're going to end up with a panel discussion with those two, as well as Joe and myself, just answering questions from all of you in the audience and really just kind of having an open dialogue about Lean and Six Sigma and business improvement and really answering any questions that you may have. If you notice, there's breaks in between each one of those, 15-minute breaks, depending on where the presentations land. They might be a bit longer. Those are intentional. Because one of the things I found valuable at this conference I was over at in the Fox Valley was just the amount of time in between the presentations to be able to grow your network and talk to people who all have kind of a common thought process, a common goal. So there's people in here who are experienced with Lean and Six Sigma. So raise your hand if you are. Put your hand up, Sarah. Hands up, right? Okay, so people that don't have experience, find these people during the break and ask them questions. Okay, so there's a lot of varying levels, varying applications in different businesses. Reach out to them, talk to them, see if you can learn from them during these breaks. All right, more crowd participation. So those of you that are relatively new to Lean and Six Sigma, what have you heard about Lean? And I will stand here all morning. Anyone? Go ahead. Improving efficiencies? Okay, good, with the resources you have. Removing waste. So by waste, I don't know if you want me to take that and kind of expand on it, but waste is really anything that gets in the way of the work that you're doing to satisfy your customers' needs. So when we're working with people, it's really, let's get the crap out of the way so we can do the actual work so that we can accomplish more of what our customer needs. Okay, so yeah, very, very good definition. So just two central core ideas that I like to use when I'm thinking of Lean. It's all about reducing time, whether that's turnaround time, how long it takes to do the activity. It's really time focused, and to get to the point over there about waste, increase customer value provided while minimizing the resource usage. So with the resources you already have, how do we use those more effectively to deliver more of what the customer wants? Okay, same question for Six Sigma. This one's probably a little bit tougher. But again, I will stand here and wait. Anyone? How about you? Say that again? So yeah, Six Sigma is highly quantifiable based. So there's a lot of measurement that goes along, quantifying. Anybody else heard anything about that? Yes, right. Reduce variation. So reducing variation with the concepts of Six Sigma. So if you think about reducing variation, you're adding consistency into the process, and you're making things more predictable, and at the end, you end up with higher quality. Okay, so there's less errors, there's less reworking of those errors, and there's less problems throughout the system. So Six Sigma essentially is, getting it right, eliminating those sources of the errors and defects, so not so much correcting them, but figuring out where they're coming from and getting rid of that and making it a more consistent process. Now there's tool sets and theories in both camps, and there's a lot of good crossover because if you think about it, they really complement each other well. And I've heard people say, well, do you want it quick or do you want it right? And the answer is yes. Right? 'Cause if you're not making mistakes and there aren't errors to correct, naturally things get done more quickly with less resources. Okay, so we're going to talk again, you're going to see some examples of these concepts that are being used in actual practice in these presentations to follow. So if you think about the continuous improvement journey, and I've emailed back and forth with a lot of you in preparation for this symposium, which thank you for the engagement. That was outstanding. Those of you that I haven't replied back to yet, it's because I didn't carve out enough time to be able to correspond back and forth with 60 people, but I'm really, really impressed with the correspondence. One of the questions that got asked is, how long is the journey? Can you get there in 1 to 2 years? Can you get there in 5 years? And that's really a loaded question because it really depends on how much resources you put towards an improvement program. But all the journeys follow this same type of path. You start at the bottom, typically, train some people, they learn some tools, and they do some things. They start to improve their processes a little bit, but it's largely an independent thing. People doing things with the tools, and so on and so forth. When you move up into level 1, that's where you really start to document, okay, how are we selecting projects? How are we training people? How are we deciding that? What does it mean to become a green belt or a black belt or other certification that you may have at your organization of these tools? And starting to solidify that. Then you move up into a partial deployment where you start to really spread those cool tools and concepts and theories into a level 2. And before I go on, most of the companies that fail at this, they fail between level 1 and level 2. They'll do some training, they'll train another group of people. There's a lot of independent practices going on, but then when the consultants leave or whoever was training, it starts to deteriorate and people look around and they're like, well, do I do another project? And the executives are like, well, I don't know, just keep using the tools. Just keep improving stuff and we'll get better. And that's, it's somewhat humorous, but that's exactly what happens. And people then it starts to diffuse and the momentum is lost and then you lose it. So when you start to get to partial deployment and full deployment, that's where you have people training people, belts internally mentoring other belts. It's clear what their next projects are. Measurement systems become visible. They're on the wall. Craig's going to talk a lot about something, what they've done at Unitypoint Health with visual metrics and being able to see the data and what's happening within their organization. And as you move up into level 4 and level 5, the ownership is passed then not to this central improvement team, but it's really ingrained within the organization. So people get hired on, and improvement is just part of the training they get. It's part of what they do, and it's just part of how that culture lives. And when you get to level 5, it becomes a self-sustaining organism. I mean, people don't even notice it any differently than regular business. So that's just kind of a little perspective. I wanted to provide that because I did get a lot of questions about what that journey really does look like. Okay, so one thing I want you to remember as we go through the presentations today is it's not about what you do. Okay, how many of us in here manufacture things? Okay, all right, hands down. How about insurance companies? All right, we've got some insurance representation. Banking, we have some people banking in here. Education, some education. Okay, I know we've even got Tim, run a recycling center, right? Right, it's a little bit different. So it's not really about what you do when we're talking about Lean and Six Sigma and process improvement, okay? It's not what you're ending up with. It's really what you're doing from a process or system standpoint to get to that. So what are the steps that we take to make whatever you're making, whether it's a product, a service, whether you're educating people, like what are the steps that you go through to make that happen? And the Lean and Six Sigma tool set is all about looking at that process and system and figuring out how to do it better. All right, so when you're listening to these presentations, don't get hung up on, well, we don't have doctors that work at my organization, so this really doesn't apply to me. Or we don't make fishing lures, so this probably isn't something that works. What I really challenge you to do as you go through this symposium today is really figure out how the system and the thought processes can apply to your organization. Okay? All right, again, thank you for coming. I'm going to now pass it over to Craig, who's going to talk about a little bit about their journey down at Unitypoint Health.
Using the stairs. See how you can train people? So first of all, thanks. I'll echo thanks to Stevens Point for hosting. Thanks to Chris for pulling this together. I think we both had been over to the Fox Cities and had similar thoughts or similar opinions about what we might be able to do here. And thanks for everybody for showing up. So this is great. Lucky for Chris, I didn't pull this presentation together just for today. So even if it was just, Joe, Monica, Chris, and I talking to each other, I'm getting a lot of use out of this presentation. And I told him that in 2 weeks, I'll be presenting this to a group of about 4,000 people within Unitypoint Health to kind of tell the story of how we've taken some tools that are available to us and got a lot of improvement work done out of it and gained a lot of ground. And my expectation is that will be the quietest group that I present to. So if you guys don't ask any questions, then we're going to be in trouble because I have higher hopes for this team. So the title here, Data-Driven Decision Making, really as we work through this, think about it as our story of how we've used clear data that gets down to the lowest level in the organization to affect change. So Chris kind of alluded to ignore some of the industry differences. I'll say that's absolutely true, and you'll see some of that in my background. But I would ask everybody who works or lives in a place where you're dependent upon people to do something and you want them to do it a certain way in order to be the most successful they possibly can be. Okay. Right, okay, so unless you have a organization full of robots and then you only need to program those robots and they do exactly what you want them to do, that's probably true. So Chris and I have known each other for quite a while, and somehow our backgrounds and our journeys through life have seemed to be very similar. So I went to Platteville as well, graduated with industrial engineering. Went back, got a degree in project management. Really, part of that was I was interested in that particular program. The other part of it was I moved back from living in Alabama, working at Boeing in the aerospace department, and could no longer go to University of Alabama for my systems engineering master's degree. So I had to find something to apply those credits to, and project management worked well. So I started out in aerospace, spent some time with GreenHeck. There's nobody in the room who understands what GreenHeck did, so we don't have to talk about that much, right, John? Actually, I would say between those two experiences, really laid the foundation for what I do now. Boeing, very highly reliable organization, very big into Six Sigma, and so I was able to get some very formal training from Villanova University in Six Sigma and variation reduction and the like. Green Heck Group was, I think, where you got a more practical sense of how to use the improvement tools to really drive business results. And their story is amazing. That's not what the presentation is about today, but find John on break and he can tell you all about it. It's a really great story of how these tools and techniques have been applied in a low volume, high mix manufacturing environment to drive great results. So from there, I joined Aspirus, got into the healthcare world, and really started Aspirus on the whole journey of how does this play into operations. A lot of different back and forth things there and different roles and different responsibilities. Eventually took an opportunity to go to Unitypoint Health, and similar to Chris, I still do some consulting on the side with mainly through the technical college. So couple of certifications on the back. So what does that all mean? What do I really do? So what I tell everybody on my team is I want you to be useful, right? Find a way to drive value in what you do. Be available. So we try and be as visible to operations as possible and always at the ready for when there's something that comes up. And solve problems and build relationships. I gave this presentation to a group of engineers that will be graduating in a couple of weeks here now, and they all had the same question. So what do you do? How do you take an engineering degree and work in healthcare? And I said, you solve problems and you build relationships, right? If you can fix somebody's problem, then you've got a career, right? And if you can fix a lot of people's problems, then you've got a good career. So it's not any more complex than that, really, I don't feel. A little bit about Unitypoint Health. So just from a scale and scope, it's about this year will be about a $5 billion annual revenue organization. We've got healthcare presence in Illinois, Iowa, and Wisconsin. 30,000 employees, right? So when we're trying to affect change, we've got a lot of hands, hearts, and minds that we have to influence. And along that, I would say the one unique thing, so I live in Madison, work in Madison, and support that region. The one unique thing in Madison is we actually have a partnership with UW Health. So when I talk about how do we influence the care of our patients, I'm not only talking about people who are employed and who have a responsibility to do things because they're a part of an organization, but it actually extends to a partner of ours and people who don't have to have this in their performance evaluation if they did the improvement work or not. And so we have to show, and this is where the story really starts, the why, okay? So data-driven decision making or whatever the like, I like to reference it as it's the why, right? If I can tell a clear story of why we're doing something, then I can influence behavior of folks. So what's the problem? What's the problem with variation? Anybody have issues with variation? So I said I'm similar to Chris. I can stand here and wait for responses all day. Yeah. Changes the results, right? Yeah, definitely. Other issues? Maintenance? Yeah, absolutely, right? Yeah, what are we dealing with? So it can become difficult if you don't know the inputs, then the outputs can obviously greatly differ, right? And all the steps in between. Sarah, so. Yeah. Yeah, so all those things, again, so talk industry, language, lingo, take it out of the mix, right? In healthcare, same thing, right? Everybody does things a different way. You get different results via different inputs, And those inputs are both in the quality metrics, the efficiency metrics, the cost metrics, you name it, right? And it's across the board. So think of your own industry. Let's say you build bikes, right? How many different ways are there to build a bike? 2. Correct answer. There are 2. I don't know the answer to that. But in general, right, you've got tires, you've got a frame, you've got some gearbox, you've got some handlebars, you've got whatever. There's not that many different inputs and outputs, right? Healthcare, it's the same thing. Everybody likes to think they're unique in all the world, but when it comes down to it, if I tell you, we're going to go over an example of somebody that has sepsis. If I tell you you have sepsis, how many different ways are there to treat sepsis? Well, I would say how many doctors are there, right? But there should be, the idea behind this work is there should be one, right? It's something that affects a person, and there's a couple of key contributing factors that we can address, right? Now, when I say this to a room full of doctors, they all look at me and they're like, thanks, engineer guy who doesn't know anything about taking care of patients, for telling us how to do our job. And where's the coffee? I'm going to go back and grab some, right? Until we can really start to tell the story in their terms. But in general speaking, that's the belief, that's the philosophy behind this work. So we're doing it to improve outcomes, reduce waste, align with best practices, bring down our costs, and learn from one another, right? So we're really trying to leverage the power of being a health system into delivering better care to our patients and better value to our communities that we serve. All right, so we had to start somewhere. Where do we start? So a couple of key domain areas. Some of them we picked because they're the usual suspects. Some of them we picked because we thought we had a good guiding faction behind it. But I'm going to tell you the story of the one that's furthest along this morning, and that's the sepsis domain. Again, if you don't know anything about healthcare, that's okay. Sepsis is a blood infection. When I started the project, I waited about 2 weeks before I raised my hand. I said, okay, clearly nobody's going to tell me what sepsis means, so can somebody tell me what sepsis is before we get too far in this project? And I assume we're treating a broken toe, and it turns out it's not a broken toe, right? So when Chris mentioned the whole industry thing, right, whenever I'm in a room talking about how do we design care processes, I'm always the dumbest person in the room. And that's, I think, why they invite me. Because if we're starting from what does sepsis mean, I have no preconceived notions around what should we do with that, right? And so when they would say things like, well, first thing we have to do is we have to go through these 45 questions to find out if it's actually sepsis or not. What would your first question be? Right. So that's definitely oversimplification, I've learned. Most people don't come to the doctor if they know what they have, but it's the right thought pattern, right? Is like, really? Do we really have to ask that many questions? Why are we doing all this work, right? So asking that why and driving into what is really going on. All right, so leading with data. So what is the approach that we kind of took on this? So a whole bunch of steps there. Most of them are the beginning stages there, right? I want to kind of focus on, I'm not going to push a button because I'm afraid if I push a button, something bad's going to happen. Is this one? Hey, I can do it. I got it. I figured it out, Chris. Thank you. So I'm going to focus on really step 4, 5, 6, and 7. And then you'll see kind of how those come together. And the reason I skipped down to 4 is one of the things that I've seen as a gap in this work is Chris mentioned visual metrics, visual monitoring of what's going on. There's a difference between showing something and showing a metric and showing something that means something to somebody. And if there's one thing that I've learned working through this is that if you put something up for someone to see, say, let's say you're in manufacturing and you put a total cost of labor for the day as a key metric. Does that mean something to the person who's coming to service the CNC mill that's in the back corner of plant number 5? right? Or let's say you're in the banking industry and you put up the total value of accounts in the bank as of today. Does that mean something to the teller who's interacting with the patient? Right? See, not really, right? So people put up these metrics, or people claim that they're doing visual management, and it's not really meaning anything to the people who affect what's going on, right? And that's what you got to get to. You got to get to things that actually tell a story to the people that are doing the work, that can help them make the right decisions, or the decisions you want them to make. And if you can do that, a lot of the items that fall down below here, putting in place interventions, implementing sustainment, right? So we'll hear, how do you sustain this work? It all becomes rudimentary, because we're giving people the right information to make the right decisions. And in my experience, 80+% of the people will do that, right? And then you have HR processes to talk about the 20% of people who refuse to do what is expected of them once you know they're not. All right, so very simple approach. Here's how we do it. Any questions? So this is one of those, you work with 30,000 other professionals, and how do you get something, right? So this is, admittedly, this is variation in our own variation work, right? We worked through, we said, how can we summarize this, or how can we start to capture the experience people are going to have as we go through this work? It got very complicated, just because you're dealing with a large organization. I like to focus people along the top here, and that kind of illustrates the steps that we go through with every single intervention, and then we simplify it from there. So looking at analysis, scoping the opportunity, exploring root causes, developing interventions. The reason it got complex is we started to interplay into here, like, what tools are we going to use? And, you know, not everybody uses the 5 why. Some people wanted to use cause and effect. And it's like, okay, so we'll list all 7 of those tools. And then not every organization used, we call it plan, do, study, act, right? But not everybody did that. Some people did DMAIC process. And so we had to, along the bottom, we said, well, how does this align? And some people used the Toyota methodology. So they were talking in Japanese terms. And so we had to add that in there. And so it got more complicated than it needed to be. The bottom line is, it doesn't really matter what your approach is, as long as you understand your approach and as long as you have a process to follow. So we, admittedly, are not following one standardized methodology across all regions, across all organizations. We're doing what works. And that's perhaps not what they would teach you in a textbook or what you would read about, but that's what works for us. And I think so one takeaway I would give all of you is, at the end of the day, you have to find what works for you, right? Anybody can open up a book or hire a consultant, no offense, Chris, and they can come in and they can tell you what you're supposed to do, right? But if it doesn't work for you, it's not going to be something that lives and breathes and remains after the engagement. You're never going to ask me to come speak again, are you? No, it's okay. All right, so we'll go all the way back to step 1, now that we've shown some of the processes, right? So opportunity analysis. We said, let's start with things that make the most sense. For protection of the innocent, I've blinded out the potential opportunity savings, but I will tell you that very top one, you see the septicemia diagnoses, the volume of patients that we see annually, the percentage of cases, and the potential financial impact of that. One, if we can reduce variation, and when we say reduce variation, that means perform at the top level of what we have in the organization, right? So if we can all meet our best performer internal, there's about a $6.8 million savings potential, right? So we decided that's probably worth going after. Let's start there. And that's where we started. So we formed kind of our approach to this work. I'll say, look at this as a chart that shows the guiding principles behind how you how you move clinical work, right? So if you're in a healthcare system, you may want to consider this. If you're not, this one might be one you crumple up and throw in the garbage. There's this whole concept in healthcare around you have to have clinicians leading and designing clinical work, right? So if you look at the first three colorful bubbles there, the blue and the pink, are all around designing clinical best practices. And then we get into actually fixing things. All right, so we set up our opportunity analysis. We set up who is going to be involved in the work. And then we had to start somewhere and say, we're going to fix sepsis, right? So step one, understanding the process. Some of these should look familiar. What did we do? We created a process map, okay? So if you're new in the journey and you don't really understand the concept of process mapping, it's going from the beginning, from the entry point to the end of whatever process you're talking about, right? So you're defining what the two goalposts are, and you're working through it to say what happens at every stage in the game. What is the necessary actions, and what are the expected outcomes of the work? And then you see those pretty yellow starbursts up there. Those are points where we said, we have an opportunity to fix this step. I'm sure you can't necessarily read this, and it's hard for me to see from this little box here, but so we set up as transportation to the hospital as our start point, right? So we didn't pick, the human being is born into this world, and in 45 years, they may potentially become a septic patient, right? We picked a point where it's like, okay, there's a problem and somebody's coming to the emergency department. That's what kicks us all off. The reason we selected that is it's close enough to the actual process that we can affect the decisions that are being made, and yet it's still early enough, so far enough away from the actual discovery that we want some actions to be taken that we can do early recognition. Doesn't mean anything to people who aren't in the medical field maybe, but early recognition for us is like a signal your machine is going to fail, right? So if somebody's in an ambulance and we know what's wrong with them when they're in the ambulance, we can prepare a lot better to be taking care of that patient appropriately. So we right away up front, we said that's where we want to know. If we can get our EMTs and our paramedics identifying what's going on with this patient, that would be really helpful. And we stopped there. We didn't say, well, now how are we going to do that? We stopped there. We said, that's something we would want in this work. And we kept mapping. So we mapped all the way out to the eventual home discharge. There it is. All right. And then, of course, as we worked through this, people said, well, not all the patients go home, right? So some of them go to a different care facility, and on and on. One thing that might be a little bit different in how we do process mapping than what you've seen before, we try to dive a little bit deeper and say, what are the key measurement points within that? So we're going to have some metric discussion right away. And we also try to put into place some of the documentation that we're going to expect to come out of it. So what are the, if there's any supporting documents that we need to have for that step. And so we will pull that into the process maps as well. Any questions on process mapping? Stop. We revisit this regularly. So as we're working through and talking about interventions, we'll pull the process map back up and say, what's currently going on. Yeah.
Is this your current state, or is this your we wish our process was this?
This is current state with the opportunities. I'll say though, our expected future state, the steps don't look much differently because the steps are broad. This map is more about it's less about waste reduction, more about variation reduction. So the variation exists within these steps of how the work is done at a more micro level. So this is a very high level process map. Good question. Yeah.
So is this something that I'm sure you're keeping in touch with management, hospital administration throughout processes? So you're working on, for example, this procedure or this situation, and you're touching in, I'm sure, with management because they're obviously the ones that had you on this process. Is this where all the questions come into play, and then you realign your focus, or you and your team go back then after hearing from upper level to?
Yeah. So the question was, how do we keep kind of leadership in the loop? Yeah. So an interesting thing happens, right? So when I present this to our senior leadership team, who's about half doctors and half not doctors, the half that are not doctors say, yeah, is there any opportunity for cost savings in this? And the half that are doctors go, so where in here do we have better care of the patient, right? So somewhere in the middle, both those things are important. But so it depends on the audience how we're keeping them in the loop, because for a lot of our administrative staff that are looking at quality metrics and cost metrics and things like that, we have to be keeping an update on those two pieces. And for a lot of our physicians and care providers, we need to be having continual discussions about practice changes and how it's going to make their lives easier and how the outcomes are going to be better for our patients. But yeah, there's a lot of interest in this work. Also kind of maybe just because I'm living through it, it's interesting how the discussions are only surfaced when there seems to be something going wrong. So if we're being successful in this work, we show up once a month and we say, everything's great. Look at, we're making things better. And the only time we really get called or asked to provide an update is if we're making somebody use a very specific example is we put in place a new order set. Again, that's healthcare lingo. And our providers went, we don't want to use this new order set. Why are you making us use this new order set? And so then we had to come and present our case as to why this order set was important and why we wanted people to align with it. So I think we do a lot of celebration of success with this work, and very rarely are we asked to come in and defend, if that makes sense. All right, moving right along.
No, I really like the high level and the detail all in one. I'm not sure everybody can read the legend, and I think there's a lot of value in those symbols that you have on there. Can you just kind of go into some detail of what those?
Yeah, so you see along here, everywhere where we pop a little icon in, so the legend, the little green chart is, that's an outcome metric. So we're assigning outcome metrics within each of these steps where possible. The purple bars are process metrics. So you'll see as we get a little deeper into this, there's a lot of process work, but we continually come back to our outcome metrics. So one of the things that we believe is that, if we align the processes that we want to improve behind the outcome metrics, that we should see outcome improvement. But it's interesting, very little can be done necessarily at those high-level outcomes to drive the outcome. So one of the key outcomes, we'll see it a little later, and for me, when I first got into healthcare, it was kind of a yucky thing to talk about, so you might have the same reaction. Mortality rate, right? If somebody says, we want less mortality, right? And it's like, okay, that seems logical. How are you going to do that? I have no idea. Right? Hey, doc, how can you make sure people die less? It's like, I can't do that. It's not what I do, right? Well, what kinds of things can we do that would contribute to unexpected death from whatever disease or condition we're talking about? Oh, yeah, there's some things there, right? So the process metrics become really important. We talked about the little starburst being improvement activities. This blue document here is standardized knowledge assets. So it's in health. Think of it as standard operating procedures, right? We call them best practices or clinical best practices or whatever terminology you want to use. Think of them as standard operating procedures, right? Do these steps in this order. All right, so we're developing those along the way, and you can see where they pull in here. Areas to prevent or avoid, or areas to consider only after careful review of indicators. So avoid the use of ethylphenidine for sepsis-associated anemia, right? I don't know what ethylphenidine is, but we're not supposed to use it unless absolutely necessary, right? So we're trying to identify some things that are potential like warnings, right? So to stay away from. The big one lately has been, right, the opioid epidemic. We'll get it right one of these times. So we would, in our process map, when we're talking about pain assessment, we would have one of those little orange markers that say, like, don't go to opioids unless you have done bing, 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 bing. And there would be 3 or 4 things to consider first. And the last one is a time-measured process. So there's timing behind lots of these different steps, such as we should be delivering antibiotics within 3 hours, right? So there's something that's being timed to say, hey, the patient got here, and within 3 hours they're supposed to have an antibiotic for this particular disease state. FYI, that is being measured, and we are being judged against it, whether we like it, agree with it, or don't, right? So good call out. Thank you, Chris. Yeah.
I have a question for you. Is the information going to be shared with us after the event?
I believe so. Otherwise, I pulled out specific details for no reason.
It
So
will be shared. The logistics are still being determined. But yeah, I got all the contact information for everybody here, so I'll be able to share that.
Second question, you have a process improvement map up there, and depending on who I talk to, process improvement or process reengineering, is there a difference? Would you do something different? Do you call them different?
no,
Okay.
that's the terminology we use. Same thing for us, right? Yeah, sometimes we refer to it as clinical variation reduction, process improvement. The terminology is sometimes important, but mean the same thing. Good questions. All right, so how do we affect change, right? So all that's nice, right? I did my job. I made a map and I told you where you should do things, but I'm done. Right? So somewhere along the line we have to say, how do we actually move from, yeah, that's nice, and we could do a better job with X, Y, and Z, to let's start measuring it, let's start affecting behaviors, right? So this was our analytics journey a little bit. How do you get to affect change? So when we started out, we started here. We said we have a couple of key outcome metrics, and we want to monitor these. We want to share them with the board of directors. We want to share them with the leadership team, and we want to talk about them in a meaningful fashion. Right, so you see number of discharges, mortality rate, average variable cost, average length of stay in both the ED and the hospital, average ICU length of stay. And they're really important, but they really don't mean anything in the same breath, right? This is where I was talking about it's really hard to approach somebody, an ICU provider, and say, geez, did you know that the average ICU length of stay is 3 days? I'd like it to be 2.5. Think you could do that for me? That'd be nice. I'd love that. And they say, why? Right? Say, well, if it's a half a day less, then our average variable cost comes down because the ICU is really expensive. So now could you do that? They say, no. And we say, okay, we'll go bug the emergency department. So the emergency department, the average length of, where is the emergency department? It's not actually on here. We'll bug there it is. Emergency department, average length of stay, 4 hours. 4 hours in the emergency department. I'd like it to be 2. 2 hours would be great. Why? Because 2 hours is a pretty long time. And, that way if people come in the morning, they could still be home for lunch. I don't know. Like, can you do that? No. Right. Okay, so, well, how are we going to actually make some meaningful change? So anybody in an organization, maybe you don't even have to raise your hand if your boss is here or something, but that shares metrics at this level and then walks away and says, we did our job. We told them what the important things are. We showed them where we got to get better. Okay. Nobody's raising their hand. You're either shy or I'm not preaching to the choir, right? So there's a couple of hands. Okay. So
I worked for a company where the owner, the single individual owner, really the only numbers he looked at were revenue and sales growth margin. And it didn't matter how you got there. Just like I said, there are times that those numbers are false. And it was very hard to convince him that that was actually the case. because it's driven by your ERP system. There's a lot of variables that can go into that number. In one instance, it showed a higher cost, but we were actually saving the company money.
Yeah, so it's a great point. At this level, there can be a lot of arguments like that. I'll point one out to you. I just mentioned the emergency department length of stay. Anybody notice that? Like any of the stats folks in the room? Right. Joe's probably like, his skin's crawling right now. Like, what's that spike? How come nobody addressed that spike and took that variation out? What's going on, right? That would be an example of, what the heck? You're going to hold me accountable for our average length of stay. And by the way, that one particular point happens to be about 3.5 days. So we did dive into it because we were like, what happened? So again, this is one of those, like, I wish I didn't ask so many questions. It was a patient who unfortunately expired. And the proper documentation wasn't taken care of until 3.5 days later. Now, the patient wasn't there. The patient was taken care of appropriately and with his family and everything, but everything wasn't closed out, right? So it looks like we had somebody in the emergency department for 3.5 days, which would never happen. We would not keep somebody in the emergency department. We would move them to an inpatient floor, right? So all of a sudden, it's like, well, it's not really 4 hours anyways. We probably are at 2.5 hours because you didn't take that one out of there. All right. So we wanted to avoid those arguments and those discussions, and we wanted to give people meaningful metrics, right? So we started saying, well, how do we start moving into the process metrics, right? So we built out an application. We said we want to notify nurses when we suspect there's somebody that has this condition, called a BPA, best practice alert, right? We think somebody has something, please do something about it, right? And we said, all right, we'll build this out, and then we'll share some information. We'll say, how long before you reply to that, right? And when you reply to it, what do you actually do? Are you doing what we asked you to do, or are you doing something else? And it's not to shame people. It's to start asking the question of saying, well, if you're not notifying the provider like you're supposed to, and instead you're calling an alert like you're not yet supposed to do, why? And some facilities said, well, because our providers are really busy, so we call an alert. An alert means everybody shows up, right? Lab shows up, phlebotomy shows up, I don't know, nurses show up, doctors show up. I don't know if housekeeping shows up, food nutrition. I'm just making it up. But everybody comes into the room, right? We're all coming together to take care of this thing that you said was a really big problem, right? And the fact of the matter is the provider then walks in and says, hey, hold on. This isn't a problem. Oh, okay, let's go back to what we were doing before, right? And it's an interruption, right? So we started saying, well, why is that happening, right? And can we drill deeper? The other thing we said is, well, if we're waiting until our ERP, in our language it's Epic, our electronic health record, is telling us something's wrong, is that early enough, right? What about if we know earlier? Let's do a screening, right? So I wish I had the before and after of this, because our before was, let's do a screening. And everybody said, yeah, let's do a screening. So I dug into our Epic environment and I said, hey, wait a minute. There's already something here that says ED nurse triage screening for sepsis. And well, we should use that. I'm like, yeah, you probably should. Why aren't you using it? Let's look at it. So we opened it up. It was 14 questions long. I said, well, so why aren't you asking the questions? They're like, because it's 14 questions long. I'm doing triage, and I'm sending somebody back into one of the emergency department rooms. They have an emergency engineer guy. We want to get him in to see a doctor. I'm not going to ask 14 questions. Right? Well, but you said we should know ahead of time. What's the important ones? 2. So what are the 2? They're almost, hey, do you have sepsis? But not quite, right? Is there a elevated temperature, and does the nurse suspect an infection? Those are the 2 questions. So it's almost, hey, do you have sepsis? And if those two things are yes and yes, or even if there's not an elevated temperature and the nurse, who's trained professional, says, I think they might have an infection, and oh, by the way, they feel so crummy they're coming to the emergency department, I think they might have an infection, and that triggers the whole process. But when we measured it by nurse, so I removed names to protect the innocent, initially it was almost all zeros. Almost all 0%, right? You can see, so this is number of cases that they see, the number of screens they actually did, average minutes to screen, and then the percentage that they completed. They were almost all zeros. We made the switch. We got rid of 12 questions. Zero means they never did it. They never asked the screening questions to find out if people had sepsis. So septic patients were, and think of this as like your quality checks along the line, right? So if a part has a missing bolt and it gets to the end of the production line and you run a quality test and you go, it's shaking too much. Oh, there's a bolt missing. Send it back. Get the bolt put in, right? Same thing in our world. We do keep track of that. No, so at the initial screening phase, we don't keep track of that piece. We do keep track of, because we still have in the background that alert that's automated. So we do track the specificity of that alert that's coming through to find out what the final diagnosis was. The problem with the triage and the screening for sepsis is that it's so early in the process that by the time final diagnosis is made, there can be a lot that would change that may either contribute to or remove from the patients having sepsis. So the way we found our path around that, though, is those numbers that you're seeing here, those are patients that their final outcome was that they did indeed have sepsis. So this is not all patients that came. They don't ask it for all patients that come to the emergency department. These are... No, I didn't do it. I think it was just... You blinked. It's the actual patients that had sepsis. So we're saying if a patient had what we indeed are trying to correct, did you do the screening? So there's been some pushback to say, like, well, how often are you doing it on patients that don't? And, you know, we probably could get that information, but it's not been real important to this journey. So initially what we were seeing is this total cases up here, the total Madison cases of 486, the initial screening was, you know, at like 4%. Nobody did the screening. And what we were able to do is improve that by making actual, real, meaningful process changes to 100%. So people looked at this initially and said, oh, you're going to shame us into doing what you... No, we're going to help and find the root causes of why you're not able to do what we're asking you to do. But then we are going to measure if you're actually completing it or not. So as you scroll down that list, it's sorted in right now in ascending order so that it looks nice and flashy for a presentation. There are some individuals that still perform underneath the 95% threshold that we're tracking, and we've addressed it in a number of different ways. We've asked, you know, one-on-one went and worked with the individuals because we have data to that level to say, can you tell me why you weren't able for these 6 patients to do the triage? And sometimes it's very good, reasonable reasons, and sometimes people will look you in the eye and say, because I don't want to. And then that's a whole different improvement path that has to be taken that I'm not going to be a part of, right? All right, so initially we started with nurses, and we picked on nurses and because they're usually nicer to me than doctors are. And then we said, well, we got to pick on the doctors too, right? So we started looking at something called order sets. Same process, and again, same thing we did was remove the names of the innocent, but right along here would be the names of the doctors that we're measuring. And again, we said, okay, best practice is that you actually utilize this order set that we've put together because, and this is again a healthcare thing, so excuse if you don't understand. An order set basically is a instruction manual that says, you have somebody that exhibits symptoms of X, Y, and Z, and you believe that that is indeed what they have, in this case sepsis, open up this thing that we give you, and all the things that you should be doing are within that electronic record, and you pick the ones that you feel most applicable. Oh, by the way, we already picked the ones that we feel are best practice, so if you want to change that decision, you have to actually physically change that decision, but otherwise just say, yes, do all those things, and then everybody will do all those things, right? So in the world of weirdness that I live in, the doctor said, that's not good. I like to decide what I want to do. I said, okay. Can you tell me what you normally do? And we went one by one by one by one around to our 35 doctors, and we compiled what they said they normally do, and then we said, hey, you're all really good doctors because you already do what we told you we wanted you to do via best practice. So now can I just make it easy for you? No. Why not? Because I don't like it, right? Would you try it? Would you have a champion try it, right? And literally the guy that was on our team, I thought I would get to do it. He said, no. He said, talk to Tepper. Dr. Tepper will do it. He does new things. So we went and we talked to Dr. Tepper. I said, Dr. Tepper, would you do this? And he said, yeah, let's try it. Right? And he did it, and he went, that was easy. And I said, could you tell the other people that? And he said, sure. And so he told the other people that, right? A little hard to see, but if you look at this chart down in the bottom, here's where we were performing. And then Dr. Tepper said, that was easy. And you can see where the performance went to, right? Straight up, right? Pretty drastic change. Again, it wasn't because of some magical pill that we had that, convinced everybody to do this thing. It was through real human interaction that influenced the change and making the right decisions to make people's jobs easy and effective, right? Oh, by the way, back to, we weren't shaming, but we were kind of shaming a little bit. What we said is, so physicians, docs, they're really interested in outcomes. And they started asking the question, so are we affecting outcomes? Good question. Rewind all the way back to the first chart. Yes, we are tracking outcomes. But more specifically, I can tell you the outcomes associated with you using the order set or not using the order set. And if you click on your name, you will see how often you've used the order set and how often you've not, and what the outcome metrics are with that, right? We have not ever once said a word or illustrated specifically who or what the outcomes are. We just said it's there, right? Now, I look at it all the time because I'm interested, right? And we're starting to have enough statistically relevant evidence around using an order set saves money, saves lives, saves resources, right? And does everybody know a doctor? They're kind of smart people, right? So they started looking at this and they went, hey, I think this thing works, right? So we made it easy. And, oh, by the way, it's doing what they want to do. It's actually having a positive impact on our outcomes. And so it becomes one of those self-sustaining principles. So then we moved to the inpatient world, right? We stopped messing around with the emergency department. We said, follow the care process map. Where does the patient go next? According to our care process map, the patient ends up in the inpatient world. Septic patients don't go home from the emergency department, in case you were wondering. They go into the inpatient world. So we're working through the same exact thing in the inpatient world and saying, can we affect this similar change with the care providers in that world? I'll skip this because otherwise I'll just talk all day. So simplifying the 7-step process down into how do we track this? How do we actually work through this? How do we monitor? Here's our 7 steps, and here's our tracking mechanism, whether or not we've done this step. And we do this for every single intervention. So this particular one is the screening tool and nurse BPA. So those were the charts we looked at first to say, are you doing the screening, right? 14 questions to 2 questions, that example. And then we're going to give you alert saying do these things, right? So this was our tracking mechanism for that. You can see all of our steps up through implement are completed, monitor is in process, and diffuse is in process. Monitoring for us will probably go on for another month or 2, and so that extends about 6 months in time. So we'll monitor for about 6 months, and then post that, we'll do a handoff, and we'll say, as a department, you're responsible for monitoring adherence to these practices that you've put in place. So that's our tracking mechanism. So somebody said, like, well, so how have you helped staff, right? Well, here's how we've helped staff. So in a very, very easy to illustrate way, that screening tool, right? So we're helping our patients because we're delivering better care. That's great, right? Back to the other half of the leadership team. How are you helping our staff? How are you making their jobs easier? How are we saving resources and money so that we can then pass that along to the greater good? We, prior to the June 6th launch of this screening mechanism, they were doing about 23,000 clicks a day, 24,000 clicks per day, right? Click, 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 click. Every time you have to ask a question, it's click, 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 click on the computer, right? Used to be they'd have to write things. We try to stop them from doing that now. Some still do it, but that's a story for another day, right? So we cut that down to 2,391, right? So if somebody says, did you help me? They say, yes, we helped you, right? We're doing everything we can to help make it as easy as possible to save you time, to make your job, give you the time to really do what you want to do, care for patients, and get you off of the things you don't want to be doing worthless documentation, right? So we're trying to keep that as a piece of this puzzle. Outcomes, where are we at today? We just via our internal metrics, again, the first one there, kind of hard to estimate that. We say that based upon our interventions, where we were at for the outcomes prior to our changes versus where we're at today, that we estimate there was 78 lives saved, right? Ultimately, that's not our decision. We do our best to care for the patients in the best way possible, but by improving that order set and having very specified care delivered to our patients, there is an impact to the lives and that we serve. 5,000 days less in the hospital. Anybody think healthcare is expensive? All right, pull 5,000 days out of a hospital, and that helps. That goes a long ways towards the cost of care. And we had a financially verified, so the bean counters in the room, or the bean counters in our room, they wanted to look real deep into this, and they verified $1.75 million savings in the first 12 months, right? And this was on one domain. We now have 4 domains going. Yes? That was over 12 months. So we'll continue tracking this fiscal year for us. It's calendar years, so we're, getting done with the first quarter. Yeah?
Craig, what's your organization's strategy for look back to ensure slippage hasn't occurred in the future?
Well, we should have had that right here. So this is something that will continue living and breathing and be reported to the board of directors and others on a regular basis.
Is there a focus to look at that periodically?
Mm-hmm. Yeah, well, definitely.
Because healthcare and many organizations produce lots of data, and it can become noise in the background.
Yeah. So we, and this would be near and dear to John's heart. So a couple of things to reduce the slippage. One of the things is, for the first time as a system, we have these domains in the incentive metrics for any employees that are in incentive plans. And so there are population health metrics, and they're actually tied to these outcome metrics. So that's a short-term item, but we believe that through these process changes, we can sustain that for the time moving forward as well.
Has Unitypoint also started to talk about when do we go back and re-examine for the next level of improvement in an activity like the sepsis work?
No, we've not, because we've not gotten through the full process map for the first swath. It's been an interesting discussion, and I'd say what our hope is, and we'll see if we can validate this or not. Along the way, we're trying to teach people to think like the project team is thinking, and to be continually doing that validation exercise, and to be continually improving. We'll see. I'm sure we'll get called back to court to provide our recommendations in the near future. So, yeah. Yeah. Are you a healthcare bean counter? So one thing that hey, we got something in common. So one thing that I think is a differentiator between our organization and some healthcare organizations. So we have a lot of lives that are fully at risk, is what we refer to it as. So the dollars are in one pocket, and if somebody uses those dollars, they go into the other pocket. Is the easiest way to think about it. But because the insurance plans are really our insurance plan, it doesn't really, if we can reduce utilization, everybody wins. And so, yeah, there is some of that like demand and where does the services get offered and who's using what services. The end of the day, that 1.75 million though was not tied to the length of stay. It was tied to a lot of other improvements in supplies and the total, because yeah, we could talk forever on this. Because the other thing is, we don't get paid on the number of days somebody stays necessarily. The government gives us a payment, and they say, you had somebody with this, and you get this much money. So if they stay 1 day or 7 days, we get paid the same thing. So there's a lot of contributing factors, but very insightful.
Well, we were just kind of relating this to our business and some things we're trying to look at. Trying to get base metrics is one challenge. Then the bean counters coming in, throwing wrenches at every number you may have is another.
Yeah. Yeah. So I end up having those discussions. Luckily, our process teams, their metrics are a lot less controversial, so they're easier to track. The actual process metrics are much more concrete than some of the outcome metrics. Yeah, one more question. I will talk all day.
Yeah. I was just going to ask, I know this is over a 12-month period, but thinking back, how long actually was this project? Because planning, a lot goes into the planning stage. So was that like a couple of months worth in that planning stage?
So every intervention we try to scope in about 3 to 4 week period. So it's really, the entire project will span probably 2 years. But as we identify an intervention, we try to move from understanding what we're trying to implement to building a communications plan around the why, and then actually doing process changes, both virtual and physical, within a week, and then doing some follow-up in that following week to see what happened. And then it extends on the monitoring phase, but we try to really make those interventions short.
Thanks, Greg.
Thank you.